Thank you, Mazani. So we'd like to move on to the next topics. Next topics is tetralogy fellow and pulmonary atresia. This is talked by Dr. Bharat Dalvi, Glenmark Cardiac Center, Mumbai, India. So welcome to Korea, Bharat. And please start your lecture.
Thanks, Teji, and good morning, friends. I have been asked to speak on cardiac morphology for congenital heart diseases, and my topic is tetralogy of Fallot with pulmonary atresia. I think defining morphology is extremely important in congenital heart diseases for making an accurate diagnosis, for planning a management strategy, and for prognostication. If you look at the four components of tetralogy of Fallot, I think they include malaligned ventricular septal defect, right ventricular outflow tract obstruction, aortic override, and right ventricular hypertrophy. Extreme form of tetralogy of Fallot, which is characterized by right ventricular outflow tract atresia, is what constitutes tetralogy of Fallot with pulmonary atresia. From point of view of morphological description, I have divided this talk into its three key elements: the ventricular septal defect, the right ventricular outflow tract, and the pulmonary circulation. Ventricular septal defect is described in a different fashions. It's called either subaortic, perimembranous, conoventricular, or malaligned, all meaning the same. Most often, these VSDs are large and non-restrictive. However, there are rarely some variations seen in VSDs. You can have complete absence of outflow septum, in which case the VSD extends right up to the pulmonary annulus. Very rarely, the VSD can be restrictive because of an accessory AV valve tissue or because of the tricuspid valve leaflet. And amongst all the variations, the commonest may be additional muscular defects in any part of the muscular septum. Restrictive VSD is not very commonly seen in developed countries because most of these patients get fixed in early neonatal period or in infancy. However, in the underdeveloped countries, many times you have tetralogy of Fallot with pulmonary atresia presenting with right-sided heart failure because of VSD restriction resulting into suprasystemic right ventricular pressure. Additional muscular VSDs pose a significant difficulty in diagnosis because of systemic right ventricular pressure. And the position of these VSDs can be so unique that they could be overlooked. Sometimes there may be a suggestion or suspicion of these VSDs at the time of doing a cardiac catheterization and doing a right ventricular angiogram. Now, these VSDs can be hemodynamically insignificant, in which case they would probably leave behind an additional murmur in these patients. But if hemodynamically significant, they can cause serious problems during extubation and deventilation, and they may need to be addressed either in the catheterization laboratory or in the operating room. And this is an example of the VSD. You see its unique position. So this is the septal band, and you can see that between the two limbs of the septal band, you have the ventricular septal defect. Again, yet another example. All these pictures I have borrowed from Dr. Anderson's atlas, and you can see that between this V, you will find this ventricular septal defect. And that is why I said that it has various names. So you can call it as a perimembranous defect because it is in the relationship to the septal leaflet of the tricuspid valve and the right and the non-coronary cusp of the aortic valve. You can call it malaligned defect because you can see that there is a malalignment of the outlet septum from the muscular septum. And then you can call it the subaortic defect because it lies just below the aorta, and you can see this angiographically. Aorta overriding the defect. So, and lastly, as I said, it's conoventricular because that is the position where the VSD lies. So these are the various terminologies probably to describe the same location of the VSD. Talking about the right ventricular outflow tract. The right ventricular outflow tract atresia can be isolated valvar atresia, it can be subvalvar with valvar, or it can be subvalvar, valvar, and might involve the main pulmonary artery. I think one of the key determinants is the outlet septum. Its length, its degree of deviation, and extent of the fusion of the outlet septum will decide on the length of the atretic segment. And this is an example where you can see that this is an isolated imperforate pulmonary valve, well-developed main pulmonary artery. And you can see this is an example of a tetralogy of Fallot with membranous atresia of the pulmonary valve. Then you can have a subvalvar atresia, and you can see this is the outlet septum which has got deviated anteriorly, and you can see that the fusion is only in this segment. So you have probably a short segment atresia, not very short segment, but a short segment atresia. Had this entire septum got fused to the free wall, you would have had a very long segment atresia. And this is an example of a short segment atresia where you can see that it is more than a membranous atresia, a valvular atresia, and a very short segment below the valve, which is atretic. And then you can have atresia of the right ventricular outflow tract, which also involves the main pulmonary artery. And this is an example of atresia of the right ventricular tract, which involves the main pulmonary artery. What you can see probably are only the branch PAs. Now, what are the clinical implications? I think if you have isolated valve atresia or a very short segment atresia, these babies can be palliated in the cath lab and can be repaired in the operating room without RVPA conduit. As against that, a long segment atresia almost always will need a palliation in the operating room, and most of these babies will require a right ventricle to PA conduit, thereby meaning that will need redo surgeries, which has significant implications in the developing world. And this is an example of isolated valve atresia with tetralogy of Fallot, which was palliated in the cath lab. And you can see this angiogram, and you can see that the valve is perforated using a guide wire, which is used for crossing chronic total occlusion. And then you dilate the valve with a balloon. And then subsequently, you can take a stent in the right ventricular outflow tract, and then you can stent the right ventricular outflow tract, as has been done here. So this patient subsequently underwent total intracardiac repair with a transannular patch and removal of the stent. Talking about pulmonary circulation, I think it can be broadly classified into three groups. One is the intrapericardial pulmonary arteries, then patent ductus arteriosus, and major aortopulmonary collaterals. As far as intrapericardial pulmonary arteries are concerned, we need to discuss three issues: whether they are present or absent, whether they are confluent or non-confluent, and the degree of hypoplasia. Because each of these issues have a direct impact on the management strategy. So absent intrapericardial pulmonary arteries means that you need to reconstruct these arteries with a pericardial tube, do unifocalization, because most of them will be associated with multiple aortopulmonary collaterals, and then construct an aorticopulmonary shunt or RVPA conduit, and subsequently go ahead with VSD closure depending upon the extent of growth and arborization of intrapulmonary arteries. Amongst all subsets of tetralogy of Fallot with pulmonary atresia, I think this is the most challenging subset technically. And this is an example of tetralogy of Fallot with pulmonary atresia. You can see the CT scan that there are no central pulmonary arteries, and most of the lungs are being fed by multiple aortopulmonary collaterals. Talking about confluent versus non-confluent, if the intrapericardial pulmonary arteries are non-confluent, then there is a need for surgical creation of confluence, and definitely that is more demanding than having a confluent pulmonary arteries. As a result, the surgical outcome in this subset is always a little inferior as compared to those with confluent pulmonary arteries. And this is an example where you can see that the right pulmonary artery is being supplied by the patent ductus arteriosus, and the left pulmonary artery was being supplied by aortopulmonary collaterals. And in this CT as well, you can see that the right pulmonary artery comes from one of the ductuses from undersurface of the aorta, whereas the left lung is being supplied by multiple aortopulmonary collaterals. Talking about degree of hypoplasia, it's very variable. The most important thing is that it's very difficult to exactly estimate the severity of hypoplasia because of the underfilling of the arteries. And this remains one of the most important determinants of single versus multi-stage repair. As you know, we use different indices to estimate the degree of hypoplasia, namely Magoon's index, Nakata index, and total neopulmonary artery index. Magoon's index, as you know, is nothing but a ratio of the right pulmonary artery at the level of the right vertebral border and left pulmonary artery before its bifurcation divided